Professor Anjana De Silva, President of the Anuradhapura Medical Association, Dr. Priyangika Gamage, the immediate past President, the Dean of the Faculty of Medicine and Acting Vice Chancellor, Professor Janaka Pushpa Kumara, the Provincial Director of Health Services, Professor Siri Baddana, the Founder Professor of Medicine in the University of Rajarata, the Professors, Senior Lecturers of the Faculty of Medicine in the University of Rajarata, and consultants of the Teaching Hospital of Anuradhapura, among them I see my former registrar, Dr. Chaturya and Dr. Nadisha, and so many students, of my past students who are now consultants at the Anuradhapura Teaching Hospital. Good evening, ladies and gentlemen. It is indeed a great honor and a privilege to be invited as the chief guest at the induction of the President of the Anuradhapura Medical Association. And this honor is greatly heightened by the fact that your President is none other than Professor Anjana Silva, a renowned, brilliant scientist. He showed his powers as a scientist when he was only a medical student, discovering 12 species of freshwater fish and unknown species of snakes. A brilliant medical student at that time. He is today a renowned, world-acclaimed scientist. He's a world-renowned toxicologist, a trailblazer in the field of herpetology, an avid teacher of parasitology, and all in all, an academic par excellence. Having read through your citation, I was full of admiration. You have received so many accolades, so many firsts, so many lifetime achievements. It was a pleasure to read through your citation. Having gone through that, you are no doubt a colossus not only in Sri Lanka, especially in the arena of medicine, in research, toxicology, herpetology. Above all, in spite of all your achievements, you remain so simple and down to earth, and that in simplicity lies your greatness. I congratulate the Anuradhapura Clinical Society, the Anuradhapura Medical Association on the wonderful achievements you have had, and congratulate the outgoing past President, Dr. Priyangika Gamage, and I wish Professor Anjana Silva, with his superb leadership, I'm sure you will take the Anuradhapura Medical Association to even greater heights in the future. When I asked Professor Anjana what I should speak about, he said to speak about my Polonnaruwa experience. I'm indeed happy to do so, because it is always with my joy that I recollect, the 3-year period I served in Polonnaruwa. I always recall it with much nostalgia, because I consider it is one of the most rewarding periods in my life. And that was the Polonnaruwa Hospital when we worked in 1986. The hospital was built during the time of Mr. D.S. Sen Naik, when he was the Minister of Health, before the first batch of colonists was settled in Minneria, Hinguragoda and Anuradhapura, because he was aware of the devastation caused by the 1935 epidemic of malaria, which ravaged Sri Lanka, causing 80,000 deaths. Now, this hospital, when we worked, had only 3 consultants. Dr. Gamini Gununtelaka was the surgeon. He was not only the surgeon, he was also the trauma surgeon, the orthopedic surgeon, and also did basic neurosurgery. The obstetrician and gynecologist was my husband, Dr. Wijesundere, and both he and the surgeon, when the anesthesia was not there, learned to give their own anesthesia. And I was a physician, not only the physician, but I was a pediatrician, the dermatologist, the psychiatrist, and all in one, and also the neonatologist. And we had only 2 qualified Sri Lankan qualified doctors as interns. There were 6 Russian qualified doctors who did not know anything about tropical medicine. So actually every afternoon I had classes for them in tropical medicine and also management of emergencies. But I must say that after about 2 months, after the wonderful experience they had, the clinical experience they gained treating so many patients with Japanese encephalitis, malaria, snake bite, and also deliberate self-harm, they became very, very competent house officers. If I go back to the earlier slide, you see the new Polonnaruwa Hospital, which was built during the time of Mr. Maitripala Senaka when he was the Minister of Health. The hospital now has 40 consultants and 8 operating theatres, quite in contrast to the small hospital that we worked in the 1980s. So this was a very, very important period of service in Polonnaruwa, because it was the last major epidemic of malaria in 1986 to 87, followed by the worst epidemic of Japanese encephalitis in Sri Lanka in 87 to 88. There was a severe epidemic of Shigella flexneri in 1987, a very high incidence of snake bite envenomation, high incidence of deliberate self-harm with organophosphorus poisoning, and of course political unrest, JVP atrocities, and LTTE terrorism. If I say a glimpse about the last epidemic of malaria, there were over 650,000 cases of malaria. The ratio of Vivax to falciparum was 2.5 to 1. And during that year, malaria was the leading cause of admission to all government hospitals in Sri Lanka. And this was our period of service in Polonnaruwa. You can see the incidence of malaria was the highest cause of admission, far ahead of ischemic heart disease, strokes, cancers, and other communicable diseases. And these are patients with malaria, alternately burning and shivering with it, waiting to be admitted and seen by the house officers. During the year, there were a total of 10,000 admissions, and more than 35% of admissions to the male medical, female, and the pediatric wards were cases of malaria. And the ratio of PF to PV was 1.3:1 during this epidemic. It is often believed that malaria is rare in the first year of life because of passive immunity from the mother via the placenta through breast milk and the deficiency of para-aminobenzoic acid in a purely milk diet. But in spite of these protective mechanisms, malaria was often seen even in the first year of life. Even if a child came with pneumonia or even with dysentery, examination of the abdomen revealed hepatosplenomegaly, indicating that Polonnaruwa in this time was an area of mesoendemic region of transmission with a high splenic rate, more than 50%. Malaria in preschool children, recurrent attacks of malaria cause anemia, growth retardation, malnutrition, delay in cognitive behavior, and massive hepatosplenomegaly. You can see these 2 children from a place called Kolkanavadia. They are boys aged 4 and 5. But you can see as a result of recurrent attacks of malaria leading to malnutrition and growth retardation. This was a case of congenital malaria delivered by the obstetrician. Unfortunately, the mother did not take malarial treatment during pregnancy, but the consequences are far worse. A child born with congenital malaria, emaciated, anemic, with massive hepatosplenomegaly, and the heel puncture done at the time of delivery showed a case of that it was definitely a case of Plasmodium vivax malaria. Another interesting case was a 10-year-old boy from Aralaganvilla with hepatosplenomegaly. You can see this child was very anemic. He had pancytopenia, and the high malarial antibody titer confirming the chronic malaria. The liver biopsy was done by me, and that was transported by train to the Medical Research Institute, and that confirmed the diagnosis of hepatic sinusoidal lymphocytosis and Kupffer cell hyperplasia, confirming the diagnosis of tropical splenomegaly syndrome. At that time, I was also the hematologist, and I did the bone marrows as well as the liver biopsies, and also did pericardial aspirations. And in fact, we were, of course, there was no case of negligence at that time or overreaching. There was no other way, so we were compelled to do those procedures, and they were all successfully done without any complications. And this was a farmer from Polonnaruwa who was admitted with acute abdominal pain. And he was admitted to the medical ward, but it was an acute abdomen. And fortunately, we transferred him to the surgical ward, and this is what the surgeon found at laparotomy: a ruptured spleen and a hemoperitoneum. Of course, this farmer had recurrent attacks of malaria, and with minimal trauma, he ruptured an enlarged congested spleen. And this was a case of intravascular hemolysis with hemoglobinuria due to G6PD deficiency. This boy, you can see, is pale, is jaundiced, and has passed black-colored urine, confirming hemoglobinuria. He too was successfully treated with adequate hydration, furosemide, and blood transfusions. My daughter Dishni was born during this epidemic. Somehow her birth was related to malaria, so I will think I'll give a small anecdote regarding this. There was a regional meeting of the anti-malaria campaign in Anuradhapura when I was 36 weeks pregnant. And it was the height of LTT terrorism. And we left the Vulnerable Hospital at about 5 o'clock in the morning, and my husband was instructed to drive fast because of, of all the landmines in that area. As we reached Anuradhapura to a Sri Lankan army checkpoint, it was quite dark, and my husband did not see the bump on the road. And suddenly, when he was speeding, the car hit the hump, and we were both thrown upwards, and our heads hit the top of the car. Anyway, nothing happened, and we continued our journey. The meeting was held successfully. That was a Saturday. The Sunday, the next day in the evening, I went into labor. And my husband was surprised when he examined me to see that Dishni, who was earlier had a cephalic presentation, was now presenting by the breech. So she had probably somersaulted, at the hump in the Anuradhapura Air Force checkpoint. Anyway, the anesthetist was not there. Anesthetist worked very hard from Monday to Friday, and Friday evening he went home. But Ajit was convinced that he always came back on Sunday midnight when the CTV bus stopped in Polonnaruwa. He got down always. So anyway, I went to labor around 6 o'clock. And unfortunately, it was not the easy breech or a breech with extended legs, but was a fully fledged breech. Anyway, because it was 1 month preterm, I was safely delivered with a small episiotomy only, without any cesarean section. Right. So that was Dishni, and the next day I was at home, and subsequently she entered the Colombo Medical Faculty and passed out. I may be boasting now, she got a first class and with distinction in all 5 subjects in the final examination, and she's now an eye surgeon in training in Canada. Hopefully she'll be returning at the end of the year. So that was also during the epidemic of malaria in 1986. During this time, I learned so much about malaria just by treating thousands of patients with malaria. There were no textbooks for us to read. There was no mobiles, internet, hi-fi, or Google. So all the information I gathered from my patients, I recorded them, and also took photographs with a standard Olympus camera. And with this, I was able to, to publish many papers and have many presentations at scientific sessions at the Sri Lanka Medical Association and other clinical associations. So this was Guillain-Barré syndrome in Plasmodium falciparum malaria. Malaria in pregnancy was a joint paper by Ajita and myself. And this hematological complications of malaria, the malathion fire, which destroyed 1 year's malathion, which was then used as the insecticide, and imported quinine-resistant Plasmodium falciparum malaria in Sri Lanka, malaria chemoprophylaxis. And all these were presentations I made at the Sri Lanka Medical Associations. The acute cerebellar syndrome complicating Plasmodium falciparum malaria, outbreak of malaria in Ragama. After I finished my period in Polonnaruwa, it was the next point was in Ragama. But at Ragama too, during that time, malaria was rampant in Sri Lanka, and there was an outbreak in Ragama. Early treatment of malaria, phase 1 clinical trial of a candidate peptide, quinine in the treatment of Plasmodium falciparum malaria, and so forth. So many research papers were presented at the annual conference of the Sri Lanka Medical Association. And I was invited to deliver plenary lectures and guest lectures at academic fora in all parts of the country. And these are some of them. During this time, I had the good fortune of working with 2 other scientists. My sister, Mantri, who's an entomologist who was working at the Institute of Fundamental Studies, and her husband, Ranjan. He worked as an immunologist. And with them too, we did lots of malaria work together. And that is their daughter, Maheshi, who is now a professor of vaccinology at the University of Oxford. And you will remember that she was the lead scientist who led the Oxford Zeneca trials during the COVID epidemic in 2021. And these were some of the joint papers that we did with my sister. They were published in the American Journal of Tropical Medicine and Hygiene clinical experimental immunology, and early treatment of malaria and its impact on malaria epidemiology. The presentation I did on neurological complications of malaria in the Polonnaruwa district received the Vijayarama Award for the best paper at the centenary celebrations of the SLMA in 1987. Subsequently, the research work I presented was awarded the S.C. Paul Oration Malaria, the Scourge of Polonnaruwa in 1988. And this was the publication in the Ceylon Medical Journal. We received the Vijayarama Award again for the paper, Malaria Transmission, a New Irrigation Project in Sri Lanka, the emergence of Anopheles annularis as a major vector. This was a combined paper by my sister, brother-in-law, and myself. And some of the publications for the general public on malaria, its prevention, and current state of malaria research in Sri Lanka. Moving on from malaria, then came the worst epidemic of Japanese encephalitis in Sri Lanka. During this epidemic, it was a common sight to see young children with high fever, headache, generalized or focal convulsions in various states of confusion, agitation, with numerous neurological changes, spasticity, floppy neck, neurological deficits. And this is a young lady who was in acute encephalitic phase for a period of 10 days. She went into respiratory failure and had to be ventilated. And in fact, those days, this was a ventilator which could even be hand operated. And with all the park cuts in Polonnaruwa, it was very useful because even a bystander could operate this Blease ventilator by hand. And these are the type of things we prefer to have during that time. And just prior to discharge from hospital, you can see she's full of smiles. So all in all, during the epidemic, I treated 90 patients with Japanese encephalitis. We had a mortality rate of 20%, which was comparable to the mortality rate for Sri Lanka, which was 19.9 among 787 cases of encephalitis in the country during that year. Here again, there was many papers written on Japanese encephalitis, the new things we learned from treating so many patients with malaria. and the result of these publications, the S.C. Paul Oration, I was awarded the S.C. Paul Oration in 1992, Japanese encephalitis, the plague of the East. And this was subsequently published in the Journal of the Ceylon College of Physicians. The next challenge was snake bite envenomation. Up to the time I went to Polonnaruwa, antivenom was not used. And the major problem was to get patients early because the pattern was to go to the Sarpavida initially and come to hospital in a moribund state. So during that time, you can see as much as 80% of patients sought alternative treatment and 60% delayed over 6 hours to come into hospital. And 80% were bitten on the head and neck by sleeping on the ground. And the cause of mortality were respiratory failure, intracranial hemorrhage, and in one state, non-availability of ABS because that day we had 3 patients with envenomation and we ran out of the stock of antivenom. And the patient had been transferred to Matale. Believe it or not, these are the snakes that we encountered. At our doorstep, a crate, when we returned from Colombo, this crate was found on our doorstep in the Polonnaruwa quarters. And that was a cobra in the theatre of Polonnaruwa Hospital killed by the anesthetist. And from that day, the surgeons were always in the habit of never wearing their boots without inverting them, making sure that there were no polangas or polongpetias inside their boots. And that snake was killed by the anesthetist. And that was a Russell's viper brought by the patient to hospital. And subsequently, the patient was so thrilled that he recovered. He stuffed the polanga and gifted that to me. And these are the children playing with the stuffed polanga in the Polonnaruwa quarters. As you know, snakes have enormous power of reproduction. And that was a tith polanga. The cut belly showed 26 polongpetio inside. So they have enormous powers of reproduction. And we have to learn to live with them. We live with the snakes and not be bitten by them. We cannot destroy them completely because they have such a power of reproduction. And you can see from this slide how the use of antivenom increased dramatically. In 1985, there was no antivenom in hospital. But by 1987-88, the requirement was 2,000 vials of antivenom serum. When Polonnaruwa became a center of excellence for snake bite envenomation, more and more patients came. And the most important thing was health education for the people to spread the message that correct treatment was available at the Polonnaruwa hospital and not to go to Sarpaveda. And these are some clinical slides. A child bitten by a cobra with hematuria. And you can see the murapola, or the watch hut, that is a sure recipe for disaster, to be bitten by a polanga when you have a murapola in the middle of a paddy field. So what is recommended is a high murapola. This is ideal because these are types of murapola found in the Polonnaruwa Trincomalee Road in Maradang Kadevala. These are meant to drive elephants away. But this is actually very important. And this is the type of watch hut that people must have, and not watch huts on the ground when snakes or crates can bite our farmers. Another interesting, you can see, these are a couple of garandias in our garden. The photo was taken by my husband. Garandias, mating garandias, the bodies are entwined, but you can see the heads are apart. Garandias in our garden in Polonnaruwa. I believe the last for the best. Monkeys were all over in Polonnaruwa, including the operating theatre. And on one occasion, the monkeys damaged the roof of Polonnaruwa hospital theatre, and no way could surgery be done because the roof was completely broken. And during a time, the weekend, when the roof was being prepared, a Polonnaruwa Kachari laborer's wife was brought to hospital in a collapsed state, spare as a sheet, pulseless. A case of ruptured ectopic pregnancy. Ajita was in a dilemma. There was no operating theatre. Sunday, no anesthetist. If he transferred the woman to Matale, the woman would have died on the way. So he had the courage and the determination and the presence of mind. He moved the patient to the labor room. There was a very experienced anesthetic attendant called Padumadasa. So he handed the boy's machine, which was moved to the operating theatre. So Padumadasa gave nitrous oxide and oxygen, and soon after, the lady's hand went down. Sir, then hurry. So Ajita went in, quickly identified the bleeding spot, and saved the woman, and sucked all the blood, and she recovered. So when you work in places like Polonnaruwa, during those times, with limited resources, manpower, limited equipment, you always have to have the courage, the determination, and the presence of mind, and the sthanocita pragnama to do the best for your patient. And that is what my husband did. And the woman is alive, and subsequently she came to see him later, and her gratitude was shown by 3 eggs and a packet of lemon puff biscuits. So that was the gratitude. So these are the tales, that is why I say it was really rewarding the time we worked in Polonnaruwa. And we think of that, not only myself, Ajita, and also the surgeon. We always look back with much nostalgia of the time we worked in Polonnaruwa. So that is a monkey story. And lastly, these are some down memory lane. This is at the time I left Polonnaruwa after 30 years. And as a visit to the ward on Aurudu with my children and my mother, we took Kyaun cookies to the ward and shared it with the children. The photograph below is the opening of the forces ward. As you know, it was the height of LTD terrorism, and our surgeon Gamini did yeoman service operating on our runaway injured in action in defense of our motherland. And during this time, a special forces ward was opened, and that was the 3 of us and the director of the hospital, Dr. Samarnayak, when we inaugurated the Polonnaruwa Clinical Society, to which we invited all the doctors from Inneria, Giritale, Bakamuna, and so forth. And we had a very active Polonnaruwa Clinical Society at that time. And so that is the experience of Polonnaruwa. And I will now, leave this quotation. What is life? Author unknown. Life is a challenge. Meet it. Life is an adventure. Dare it. Life is a promise. Fulfill it. Life is a struggle. Fight it. Life is a goal. Achieve it. And finally, life is a duty. Perform it. So that is what we have to do as doctors. Perform our duty to the best of our patients. And finally, sunset over the Parakram Samudra. That is my husband. It was often we went for a swim to the Parakram Samudra at the end of a hard day's work. So thank you very much, Professor Anjana Silva, for inviting me. And I'm filled with joy to see the Rajarat University, with so many academics and all the good scientific work that the Anuradhapura Medical Association has done. And I wish you all the very best in your tenure. May you reach great heights during your tenure as president of the Anuradhapura Medical Association. Thank you, ladies and gentlemen, for your attention.